We're live.
Joe says he's backstage. There's Andy.
Yeah, I got them both now.
All right. Good afternoon, folks, and welcome to Inspire Respiratory Critical Care's March panel discussion. Today we will be discussing non-invasive ventilation. My name is Keith Lamb. I'm a respiratory therapist. I work for the trauma service at the University of Virginia. And we'll go ahead and introduce each other real quick. Go ahead, Tom.
My name is Thomas Prano. I'm a respiratory therapist in Canada, a consultant and educator.
Donna. Paging Dr. Tanner. We'll go right ahead to Eric.
Hi, my name is Donna Tanner. I'm a respiratory therapist in Cleveland, Ohio at Cleveland Clinic.
And Eric?
My name is Eric Krenner. I am a respiratory therapist in DC at Messer-Washington Hospital Center.
And Hollywood?
John Ancrott, flight respiratory therapist in Orlando, Florida.
Dr. Scott?
Brady Scott, respiratory therapist and program director at Rush University in Chicago.
Andy?
Hi, Andy Klein. I'm the clinical education coordinator and assistant professor at Rush University.
And Joe?
Joe Hilton, clinical applications for Hamilton Medical, respiratory therapist for Advocate Atrium Health in Charlotte, North Carolina.
And I'd like to add just a little footnote here. All these folks are volunteering their time. There's no money exchange between anybody. Nobody's making any money. Everybody's just really passionate about what they do, and we call ourselves experts. If you look up any of these folks that are on the panel discussion today, if you Google Scholar them or Google them, you'll find that every one of them is extensively published, extensively involved in committee work and really important educational and clinical activities. So I encourage you to do that. Tom, you want to get us started on the talking points? So I think that first, I'll go through these really quick.
I was muted. There we go.
Yeah,
go ahead.
Okay, there you go. I didn't see your lips moving.
That's okay. Oh, so these are the talking points. The topic of the discussion today is what do the guidelines say, but we thought we'd quickly go through some talking points before we get to what do the guidelines say. So let's start it off. Who wants to define NIV? You're going to make me do it?
No, I'll do it.
There we go.
I'll go out there. So to me, some of this is opinion, right? And so just right before we came live here, we were talking a little bit about what we consider non-invasive ventilation. But to me, non-invasive ventilation is done without an endotracheal tube or a tracheostomy tube. It's there's some discussion about whether or not high flow nasal oxygen is non-invasive ventilation. My personal opinion is I do think that it contributes some to ventilation. So I consider it a non-invasive ventilation. We're not going to talk much about high flow nasal cannulas today because we've decided that next month's discussion panel is going to focus on that. But we will mention it a little bit in terms of discussing some of the guidelines.
Keith, I think.
Sir.
Sorry, Keith. I was just going to add. I think it's worth mentioning that a lot of guidelines and publications now are generalizing and calling it NIRS, non-invasive respiratory support, to try and mitigate some of that confusion over, for example, is high flow ventilation, because people could argue that, sure, it helps with anatomical dead space, but does it provide ventilation in terms of the classical positive pressure during inspiration? And the answer is no for that. But so many of the guidelines are now calling the NIRS, non-invasive respiratory support, in order to include other therapies that may not fall under the traditional NIV.
Exactly. So not straightforward, but certainly maybe dialing in on a broader definition for respiratory support. Anybody have anything to add to what I said about NIV definition? I think that if it's provided with a mask instead of an artificial airway, then it's non-invasive ventilation. And so
I think you could say, and providing a positive expiratory and or inspiratory pressure, right? Because if you're going to say ventilation, I think you could go into the semantics with the same thing of CPAP versus and high flow, right? None of them are providing a positive inspiratory pressure for, you know, a true assistance in ventilation, right? So I think you just kind of have to be broad. But then you get into the weeds with high flow, and does it provide any positive pressure, right? So I think since 17 and then now to whatever, 21, 22, 23, all the high flow guidelines that are coming out, yeah, I think it is better and will clear up a lot of the confusion, just non-invasive respiratory support, especially because there's so much overlap. You know, post extubation and giving breaks and all that other stuff, that it is a much larger thing that is difficult to weed through and separate out individually, right?
Which is why I think the shift towards non-invasive respiratory support is actually an improvement, because I don't know that we need to debate it, to be quite frank.
Yeah.
Because it's, you know, so I think we can treat hypoxemic respiratory failure with either. Sometimes you can treat them with both, or whichever one the patient prefers. Whether or not there's a carbon dioxide elimination, you know, improvement there with some of the things, I think is still up in the air a little bit. But I think the non-invasive respiratory support is the right language going forward, because now I think we have a much better, like you said, Eric, we have a much better understanding of the use of high flow nasal cannula than we did, you know, 5 years ago. And so I think we can start putting them together and think about them both and how we can utilize them or escalate or de-escalate from one or the other based on the patient's needs.
yeah, well said.
Yeah, you do need to retain some understanding, like clearly, because if you're going to lump them all together and say they're the same thing, then that's going to be the messy part. With I agree that non-invasive respiratory support is so much more beneficial all lumped together, but the exact mechanisms we absolutely need to keep them stratified and leverage them for their advantages and get out of town when it's disadvantageous, right? And so, it's a little bit of both, right? A little bit of both.
Agreed.
What about some contraindications? And again, this comes down to which form of non-invasive respiratory support are we discussing for contraindications, you know? So, I mean, if we think of the classic, as Eric mentioned, the classic definition of, you know, essentially positive pressure by mask was the initial basic understanding of what NIV meant, and that could be CPAP or BiPAP. You know, you're just providing positive pressure via a mask strapped to the face. There were many contraindications that had a lot to do with the fact that you're strapping a mask to a face, and which obviously changes when it becomes high flow nasal cannula rather than a mask strapped to the face. So anybody want to discuss some of the contraindications?
How do you guys feel about the use of non-invasive ventilation for palliation and for end of life? Is that a contraindication?
I think that's a debate that we continue to have in the way of palliative care, because whether it's a DNR, DNI, it's not a do not treat your patient.
Right.
So I tend to fall on the side of treating the patient, and if that's something that can make them more comfortable, then I'm all for it. But, you know, we talk about the contraindications. We can talk about those absolute contraindications of respiratory arrest, not being able to protect your airway, unable to control your secretions. So those would be absolutes in my mind, but there are others.
Sure. I mean, I think you're right, John. The absolutes are like the really, really decreased level of consciousness where somebody just simply needs to be intubated, and non-invasive may not be the right thing, or maybe some degree of severe hypercapnia and acidosis. But back to Keith, your question about, I think so. Palliation is interesting because sometimes I think we lump together hospice and palliative care and those type of things, I think incorrectly. Palliation is to reduce suffering, right? And so then it becomes a discussion with the team about what the objectives are at the end of life. And whoever just said it, I'm not sure. I think maybe you, John. DNI doesn't mean DNT, doesn't mean to not treat and ease suffering. So that is definitely up for debate. And so I, at one point in my career, was not for its use. I'm not sure I'm the same way now.
Yeah, I agree. I tend to struggle with this on an individual case-by-case basis. And, if you have somebody that's a do not intubate, but at the same time, of course, we're going to treat them. Then is somebody who's not do not intubate, are they a candidate for non-invasive ventilation despite their neurostatus maybe, or how in everybody's opinion, how does neurostatus play into whether or not you're going to strap a non-invasive mask on somebody?
I think this plays into one of our comments too that we just received from Reggie. Communication. If your patient does your patient communicate that they, find it comfortable or uncomfortable? I mean, this is a whole nother level, right? Because as John already mentioned, it's not about whether or not it's obviously not a do not treat, but at the same time, is it comfortable? We think, if they're having a struggle breathing and we apply the mask, is it more comfortable? Because I know we've all seen patients that we assume it's going to be more comfortable because it's going to help with work of breathing. But the minute you put that mask on, they just want to tear it off because they hate it. So the question is, are they communicating that? And then, of course, there's the question of, do you want to prolong life? Because sometimes NIV has been used in palliation simply to buy more time for family to arrive without actually, going through with intubation, which they've, if they've requested that they don't want that. But really, communication becomes another challenge. The minute you put the mask on the patient, many patients, if they are conscious, don't want to keep the mask on because they just want to talk with their family. And I think this is where the role of, high flow can be beneficial in terms of providing a little bit of support, but maybe not as much as would be required to prolong life if that was the goal, is to just extend briefly until family can arrive. But this is definitely a challenge, is that communication piece.
Yeah, Keith, I agree with the neurostatus piece. That's a double-edged sword. You want to apply it, but if your patient can't maintain their airway and they aspirate, have you really done anything for your patient positive?
So,
right. And yeah, go ahead. I'm sorry.
No, it's good. I was just going to add, and this is a conversation we're having internally, and the group can certainly weigh in on this. But if you have those borderline patients, those patients with a moderately compromised neurostatus, but somebody that you're not ready to pull the trigger on intubating, and if they had a better neurostatus, they'd be a slam dunk NIV, and then but you're like, hey, I'll throw NIV on them as long as I can monitor them closely by maybe putting a sitter at the bedside, things like that. So that's been our policy here, but we're starting to get some pushback from the nursing staff on, well, we don't really have the staff to sit one-on-one with them at the bedside just because we made the choice to put them on NIV when maybe they were in that questionable status of, should they be put on NIV, and can we accurately protect them if they do start to vomit and aspirate because they don't have that neurostatus to communicate appropriately. So kind of interested in what the rest of the panel thinks about that, and how they think those patients should be managed if we do make the decision to do non-invasive in those borderline circumstances.
Well, I can briefly comment on, as my history with dealing with students in the clinical setting, where we tell them, there's some absolute contraindications, and one of the absolute contraindications NIV, as already mentioned, is essentially if your patient is completely unconscious and not aware. Having said that, I always added that with a but. How many of us on the panel, raise your hand, have you put, and we all know what type of patient it is, but let's, without saying that, how many of us have put NIV on someone who's clearly unconscious? And I'm going to go ahead and guess their CO2 is extremely high and they're a frequent flyer, and we actually already know that this works for them. right? This was always the caveat. I worked in a center that dealt with many of the patients. Like in the city that we were in, if you were picked up by paramedics and you were a COPD patient, respiratory issue, as expected respiratory acidosis or unconsciousness due to that, they were automatically brought to our hospital. So we had many patients that were like, oh, Jim is back. There he is again, unconscious, CO2 is 120. And that, 15, 20 minutes of BiPAP, he's going to be asking you for a sandwich. So there's always those caveats. But unfortunately, if you don't know the history of the patient or the fact that they are this type of patient, it is a huge risk factor, obviously, because you don't know the status. You don't know the last time they ate. You don't know if they felt nauseous prior to being unconscious. And you don't know if applying that mask is going to lead to, I think with patients that are severely hypercarbic, many of the chances we feel like, yes, we could intubate them based on all the signs and symptoms, but we've all seen, I guarantee all of us have seen those patients that actually turn around with NIV and avoid getting intubated. And, they don't meet that criteria of like someone who would ideally be a candidate for NIV, but we just know that it's going to work because we've seen it before. And I think that's where the expertise or the, I guess your experience comes into play, the whole art of providing care.
I think that speaks to individualizing care. But also, I would be willing to bet that everybody that raised their hands in here, whenever they placed a patient on that borderline patient that you're uncomfortable with, you were probably having a direct discussion with the physician at the bedside, and you probably didn't leave.
You had the intubation card outside the room.
Yeah, you didn't go far. So what you didn't do is you didn't apply NIV and then go upstairs and hope for the best. I would be willing to guarantee that's happened across this group, which I think is an important part of that decision. I've literally stood in that same exact patient population, Tom, that you're talking about, stood there with a physician who said, I've had this patient before. They turned around. So what can we do? And it's really hard to do this, but that intubating them could be very difficult for the patient as well. So, but again, I guess the point I'm trying to make here, like you said, the art of this is also really close monitoring of a patient, and everybody in the room, including the physician, being aware of what's going on.
So to dovetail on that, and you guys just nailed it, and Tom, with just experience alone, that definition kind of plays into another contraindication, being untrained staff. So like Brady said, and across this group, I have seen it myself. I guarantee we've all seen it, where they do strap it on a patient and then they go off to do something else, or they go upstairs and don't monitor the patient. And that falls back, I think, on the RT being the advocate. And like Brady said, being that liaison with the physician and, here's our patient. This is what's going to happen. I'm going to stay here the whole time. We're going to make sure this guy doesn't get intubated, as opposed to slap a mask on, disappear, 30 minutes later, we're having a code. Yeah. So contraindications, untrained staff. There were some papers in the early 2000s that kind of looked at this. And when it comes to RTs, we are the ones that should be running this and the ones that should be driving that bus. So,
yeah. And I agree. The comments I made earlier were clearly, with that experience, we all know that these aren't the patients you walk away from, period. Like, that if these patients don't improve, and this is actually another point maybe to bring up, but NIV success is measured in hours, not days. So within 1 hour, you should be able to know whether or not your patient is succeeding with NIV. It's not something you need to wait 12 hours, 24 hours. This is something that success with NIV is measured in hours. And I don't mean many, many hours. I mean, within a few hours, you really should get a better idea or sense of whether or not that patient's improving or not. And lack of improvement is a risk factor for NIV failure. And whether that's PF ratio or CO2, coming down, et cetera, these positive responses are predictors of success.
So if you were designing, not necessarily, I don't want to use the word protocol, but application strategies type of thing, would you then kind of say decrease mental status due to hypercarbia or presumed hypercarbia versus presumed neurologic injury? That's kind of the dividing line, that If it's a neurologic injury, and that is what's causing it, then that's the no-go. But if it is a neurologic and due to a gas exchange abnormality, then that guy deserves a shot. Is there anything else there in that mix that would, drug overdose?
It's just pharmacological, I was going to say.
Yeah, drug overdose. You're waiting. We know Narcan's coming and it's almost there. They're somewhat still respiratory depressed. What are we going to do, type of thing. So I think it gets tricky, right? But I think that there's clear indications, right, that the neurologic injury with the inability to protect an airway, I think is fairly clear. Like I
think the pragmatic or the true clinical challenge comes down to, if you're in an emergency department, sometimes we're not aware of the actual underlying cause prior to being asked to assist with, what should we do? Should we try NIV? And that's where the bigger challenge. So I 100% agree with you, Eric, but I also want to acknowledge to any clinician that might be watching that's in the emerge being like, well, sometimes I'm asked to do it and we have no idea why they're unconscious. So I think
those are the questions, right?
Yeah, those are the questions. Those are the things you need to determine. The question is, do you start it prior to knowing? I think regardless, if you're in an institution that, it's the doctor's word over yours, where they're saying, I want you to start NIV, and you're not quite sure the intent, the key is to ensure that your protocols involve a very short turnaround time for assessing response. So whatever that response may be. So whether it's a baseline gas, and then 1 hour versus 4 hours, like having routine protocolized check-ins for success, and then, having those discussions sooner rather than later as to, we didn't know why this person had it coming in. We found out now that it was neurological. The gases are essentially normalized, but they're not waking up. I don't think we should leave the mask on because they're not likely going to wake up. So I think ensuring that regardless of your situation, if you know the patient, having a protocol is helpful. And then having a backup in your protocols, if you're unaware, then making sure that this looping around to ensure that you're assessing a change in status with the patient so that you can make those decisions.
Yeah, I agree. I mean, to me, it really just boils down to whether or not something is reversible. And easily temporized, right? And most of the literature from the 2000, late 90s, early 2000s that talked about, okay, who are the patients that we should use non-invasive ventilation on? And this is long before high flow was really a thing, et cetera. Said COPD patients and CHF patients. Those patients are patients that they may be hypercarbic. Then non-invasive is probably going to support them until that you can fix whatever the acute issue is that's causing them to be hypercarbic, or somebody's going to be diuresed, and anyway, easily reversible. And sort of a quasi contraindication was something that was going to last a few days, like significant community acquired pneumonia, or something that was going to require a pretty lengthy course of antibiotics, et cetera. But yeah, I love the use of the word art in our profession, because so much of what we do is not obviously supported in the literature, and it takes some experience, and it takes some understanding of the science, and it takes some bedside decision making by the clinician to determine whether or not, again, we've all seen these significantly hypercarbic COPD patients that have this CO2 narcosis that is going to turn around. It's just a matter of how long is it going to take. Sometimes just a few minutes, and sometimes to just get them over the hump, and sometimes a little bit longer. And we've also seen these patients that really have a neurologic insult that has affected their their neurologic status, and that's a whole different patient, a TBI, or a patient that's, I don't know. There's a laundry list long of patients that can have neurologic insults, but And the important thing is to understand, in my mind, the important thing is to understand the difference, right? And when that will help you determine whether or not you're going to push for something that's more invasive, or if you think that somebody could be temporized non-invasively.
Just to throw that out there, would you drop a gastric tube, put it to suction, and empty their gut, empty their stomach, put it on?
Yeah, I mean,
Yeah,
how
leave it
many
in.
of us have intubated somebody that that just got off a binge of drinking as much beer and eating as much pizza as they could, and then gets intubated? I think that that can be nightmarish, and I don't think it's a bad idea to put an NG tube on somebody who
That has that wavering neuro status, and
yeah,
you're of question. No.
yeah.
So I pulled a question on the screen, just to make sure we get through some of the questions and get through our talking points there. But team's expertise regarding NIV, nasal prongs / mask to relieve air hunger versus max out in 7 liters high flow nasal cannula. I have an initial comment. I do know that depending on the device you're using, 70 liters per minute, although there may be a physiological benefit, the humidifiers may not provide the optimal humidity that we're aiming for with high flow nasal cannula at 70 liters per minute. In fact, if you talk to, again, this is not sponsored by Fisher and Paykel. I just know they're a very common humidifier device. And if you ask them the maximum flow at which they stand by their humidification, they're going to say about 60 liters per minute of flow. Above that, it starts lacking in its ability to optimize the humidity to the patient. Having said that, I think air hunger essentially or routinely has been something that we tend to try to reduce work of breathing, which I think brings us into what are the advantages of NIV, right? If air hunger is involving a lot of work by the patient, then perhaps a little bit of NIV with some positive pressure may help. Again, this depends on the underlying condition, which we can get into once we get to the guidelines. We can talk about, is this hypoxemic failure? Is this respiratory failure? And if it's hypoxemic failure and the patient has air hunger, then hypoxemic failure with significant air hunger, perhaps something like high flow nasal cannula would be more beneficial or more optimal compared to strapping on positive pressure that may increase transpulmonary pressure and the potential for lung injury. Any comments from the group regarding handling these situations?
No, I agree with you 100%, Tom. And you covered this, I believe, in Indianapolis, where you had hypoxemic respiratory failure and they were put on non-invasive, and the PF ratio is less than 150 or even less than 100. We know they don't do well. Over 85% of these patients get intubated. So while there are advantages to respiratory muscle unloading and improved dyspnea and better gas exchange with these devices, we need to be very careful not to hurt patients who probably need a mechanical ventilator if they are certainly hypoxic, because that NIV or the heated high flow is not going to cover these patients adequately. So that's where I think we get, like Tom said, you kind of got to know what we're dealing with to get the advantage of this.
Another question here. What are your thoughts on hypotension being an absolute contraindication versus relative contraindication for NIV?
So I think you have to go back to what's causing it.
Yeah. You go, Joe. Yeah, I was going to say left heart failure, but go for it.
Is it a pump issue? Is it a tone issue? Do medications rapidly fix that and allow you to use more pressure? Yeah, I think you've got to go back to the physiology if you know it. And sometimes you may not. But
Yeah, I mean, it depends on why somebody's hypotensive, right?
Yeah.
If just like you guys just said, if it's hemorrhagic shock, or if it's distributive shock, or is it something that I've always been a big believer in positive pressure doesn't do much for shock, and particularly if somebody is intravascularly dry, and so. Again, case by case basis. I don't think that I certainly wouldn't call it an absolute contraindication. If somebody's so hypotensive that their neuro status is being impinged upon, then that might be a different animal too.
Yeah, I think aside from active cardiac arrest, most of the absolute contraindications, you can think of a scenario where it's relative, for the most part. And again, it comes down to patient wishes. If someone's hypotensive but refuses to be intubated, does it matter that it's a contraindication? If they want some form of support, then they have to understand the risk. But you have to, you have to be able to relay the risks, or the physician can relay the risks to the patient in terms of, you're sick enough, you have a high risk factor of failing this mask on your face. The solution typically would be to intubate, but if that's against your wishes, then it comes down to, it might be an absolute contraindication, but if that's all the patient's willing to accept, then this is where things become more relative, I guess.
So I want to go back and just say one of the things that I don't know, that I have a much better time optimizing invasively, but it's certainly applicable non-invasively, is when you were talking, Tom, about like excessive inspiratory workload, right, and that sort of thing. I just feel like we are more ready to address an optimal lung volume with expiratory pressure and decrease compliance as the source of the work, right? And to increase our PEEP instead of wasting a whole bunch of inspiratory pressure on a collapsed lung, right? And less so, just my anecdotal kind of view, less so in non-invasive, right? Everything is fixed with inspiratory pressure.
I think there's a history behind that, though. The expiratory pressure on NIV is actually one of the major components of leak when it comes to mask application. The minute that patient's exhaling against that pressure, because it's a different kind of PEEP, right? So on the ventilator, we have these expiratory valves that keep it in there, versus NIV, it's just a different pressure being forced at the patient while they're trying to exhale. So most of the research studies, and I'm agreeing with you, Eric, like traditionally, invasively, we use PEEP it's definitely a viable option for adjusting, both for effort, for oxygenation. Like, it's actually one more setting we can tweak to see if that is what helps, but it becomes less of an option for NIV. Having said that, I've definitely come across many scenarios where patients on NIV were on an excessive amount of EPAP and actually struggling, and because we were thinking, oh, this is what I have to do, there's an oxygen problem, I'm going to turn up the EPAP, and then you come by a patient who's on like EPAP at 12 and an inspiratory pressure 4 above that, and as soon as you reduce the EPAP, the patient's just like, oh my God, thank you, I can breathe. So we have to think differently. So I agree with you, expiratory pressure, lung volume is essential, but it's actually a harder thing to do with NIV. And most of the studies, if you read not only the discussion portion, but even the results, but it's usually in the discussion, a lot of studies on NIV will comment on the fact that the highest level of EPAP they were able to achieve on average was something like 8 centimeters of water. And it'll say due to excessive leaks. This was actually one of the components of the randomized trial in Chicago of helmet versus face mask NIV. There's a comment in that paper saying that in the NIV group by a mask, they had a minimum amount of pressure they could achieve before leaks were like basically unacceptable. Whereas with the helmet, this was one of the benefits of the helmet, is that they could increase the EPAP. And this is why they thought there may have been a benefit to those patients, is the ability to give more expiratory pressure as a option for improving lung volume, as you mentioned. So I think the device and the interface plays into that, but the traditional NIV via mask becomes very challenging to do exactly what you described with that expiratory pressure.
Yeah.
I think it'd be interesting too to look and see if, for example, an open system, like just purely for example, a V60, where you've got a single limb circuit, some kind of expiratory port at the mask, versus a dual limb type system that has an expiratory valve, that if you can control your leak, you may be able to eke out a little more respiratory pressure on that end.
Although, correct me if I'm wrong, I know, Eric, you have a lot of experience with bench studies and test lungs, et cetera. When a ICU ventilator is in dual limb mode NIV, my understanding is, I thought, maybe it's different with some ventilators, I thought it doesn't function the same way as PEEP does invasively. It actually comes down to a inspiratory and expiratory pressure. Like, is it utilizing the PEEP valve, or does it depend on the ventilator?
I think it depends on the ventilator, but I think it does revert a lot more to the to the flow.
Like a traditional NIV model where during expiration it's just giving a different level of inspiratory flow to maintain that expiratory pressure. Yeah, I'm not sure. So just to comment, Joe, like I agree that would be an ideal situation, is like how is it with dual limb versus single limb? But I think many ICU ventilators might adjust how they deliver ventilation in the NIV mode, where they may not be utilizing the PEEP valve the same way they are during invasive. And again, I could be wrong, but I have a feeling that it's more traditional.
You switch from threshold resistance to a
flow-based pressure maintenance. Yeah.
I agree.
So someone here is saying it depends on the vent and the control system. Yeah, but I think overall it's not a. We can't just assume it works just like an intubated patient on dual limb.
Correct. And there has been bit studies that showed a difference between turbine-based machines and machines that use fully compressed air as well. The turbine machines do better.
Mm-hmm.
So
I feel like that's more. I struggle with the solenoids on inspiration and in maintaining flows. Keeping up with them. So it was going to be one of the other things that I, kind of went down towards later. But you brought it up, Joe. Yeah, the difference that we see, and it's just glaring in the ED if they grab, a solenoid vent versus a turbine, and they're trying to do non-invasive, they're always like, oh man, this is awful, it's failing and whatever. And we just switched the kind of BDU, and it is, and this is anecdotal commentary. Clearly, we just have much better luck in those really difficult air hunger patients with the turbine-driven vent, for sure.
Sorry, just reading the question from.
Yeah, me too.
Yeah, so I mean, I would take. I guess I could take a stab at this. I'd say, yeah, it's common to sort of rely on non-invasive respiratory support at first until you figure out what the etiology of the increased work of breathing and the acidosis is.
I think acidosis would be a clinical reason to consider NIV with positive pressure over high flow nasal cannula. All of the studies so far that have any comparison with NIV or high flow, definitely NIV is going to be your first line therapy for respiratory acidosis. The guidelines, as when we get to it, the guidelines do have a strong clinical recommendation for non-invasive or BiPAP, I guess we could say, for respiratory acidosis, particularly in patients that have an underlying chronic condition like COPD or emphysema. Probably not as common to use CPAP in these situations for respiratory acidosis, like standalone CPAP, continuous positive airway pressure. And then until work of breathing is normal, this is questionable. You hope that as the CO2 comes down, the work of breathing will come down. If the patient is able to tolerate their work of breathing, then that's one thing. One of the problems with waiting for work of breathing to be your endpoint is that you don't know how the patient breathes outside of the hospital. I say with patients with fibrosis, for example, they always look like they're working hard to breathe. And so we're not going to correct this in the emergency department, in the ICU, or in the hospital. They're going to go home breathing the way they breathe at home. And sometimes we're unaware of that. So we might work of breathing might be an ineffective endpoint for some patients, I think.
I'll add, so Savannah, so it sounds like probably, if I were guessing, you probably had, and again, I'm guessing, I don't know. You probably had somebody who had an exacerbation of COPD. And from a student standpoint, I would say that, yes, that is a very common to use non-invasive ventilation. Like sometimes we say BiPAP or bi-level non-invasive ventilation when you have an IPAP and EPAP or a level of pressure support on top of PEEP. That's very common. And those patients sometimes have a acute on chronic respiratory acidosis and some degree of work of breathing. But I think somebody said earlier that, the whole point is this, maybe what you hope is this is somewhat reversible. And so you put them on the non-invasive ventilation, and perhaps you provide them with some bronchodilators and things like that to help, hopefully the condition that is kind of put them in this exacerbation kind of starts to get resolved a bit, and you kind of support them through that. So if it were a situation of like an acute exacerbation of COPD, then yes, actually the literature will be strongly supportive. And to go back to whoever said it, maybe Tom, this would certainly be where you would see a different use of non-invasive versus high flow. So if this were my patient in the emergency department, I would opt to go to non-invasive ventilation first for this patient. Again, if they were an exacerbation of COPD, so very common. I don't know if that was your situation, but if so, that would be a common use. Yes.
I think another thing too, Brady, with what you're talking about, I think that what I'm seeing is sort of a trend toward physicians and other team members are hesitant to go to anything invasive unless a patient has failed non-invasive by some standard. So they don't. I mean, there's a few exceptions to that, obviously, but I'm saying if someone is even remotely a candidate for non-invasive ventilation, even if they wouldn't be your slam dunk patient or somebody you might consider it if you were in a vacuum, I find a lot of times it's like, well, have we tried NIV yet is a question, even if that patient may not be one that, like you described with COPD, that all the literature supports doing. Maybe it's a different kind of acidosis with the worker breathing component, maybe even a metabolic acidosis where the worker breathing becomes extreme and they don't want to intubate right away. They want to see if after an hour or something on non-invasive, they see some sort of improvement that would justify not placing the patient on a ventilator. I don't know what the rest of the panel is.
Are you talking about like somebody with an exacerbation of asthma?
Yeah,
like
perhaps
severe acute asthma.
Yeah, perhaps that, or perhaps just a high worker breathing of unknown origin, like what Tom described. Even if your gut is saying, well, we're probably going to end up intubating this person, for the most part, they're hesitant to say, you're right, let's intubate. They want to see them fail NIV first in those cases. A lot of times, I feel.
Which is unfortunate because that's failing NIV is a risk factor for higher mortality. But I agree with you. Sometimes we wait too long, and unfortunately, failing NIV is not associated with positive outcomes. I'm just wondering, Keith, if we should address some of these additional questions or move through the talking points. We're down about 15 minutes left.
Yeah, we're running over a little bit, I think, but I think that if you don't mind, I can summarize some of the remaining things real quick, and then we get into the guide. What do the guidelines say? What are the advantages of non-invasive ventilation? I think the advantage of NIV is that you don't expose patients to the disadvantages of invasive ventilation, and that's difficult, as we've discussed sort of in depth here now. That's sort of difficult to tease out sometimes, because even non-invasive ventilation now, we understand, certainly has iatrogenic components to it. They can cause lung injury, and even high flow nasal cannula, which we'll talk about next month. But so the advantages are certainly that you don't expose to some of the disadvantages and harmful components of invasive ventilation. What patient benefits? I think overall, the overarching consensus is that it's somebody who can be fairly quickly and easily mitigated and treated for whatever the underlying cause of the respiratory failure is. There's some outliers there for some of the palliative patients, certainly. It's high flow nasal oxygen or cannula, non-invasive ventilation. We'll leave that for next month, but certainly this overarching definition now of non-invasive respiratory support, all of these things would neatly fall under. I put this cuirass bullet point on here. I don't know much about it. I've never used it before. I read stuff about it when it comes out. I know, Eric, you've done some work with, I don't know how much you can talk about it, but I think that you are looking at augmenting invasive ventilation with negative pressure ventilation.
Yeah, I mean, we were using it in ECMO patients, so this is like all the way on the other end of the spectrum. And so that's my experience with it, and not necessarily in, necessarily impending respiratory failure or otherwise, as we're talking about the use of NIV.
Right.
So
I mean, negative pressure is the original gangster. Is the original.
yeah.
The OG, yeah.
It is the OG. It's the original version, right, Eric? Am I right about that?
Yeah,
right?
you are.
And I think
you
by
are.
definition, it fits the non-invasive respiratory support
It sure
definition.
does.
Absolutely. I don't think
Yeah.
any of us would argue that.
Sure does.
I think it comes down to, again, how we define NIV. And if we go traditionally with positive pressure applied via mask, then
Right.
the answer is no. But non-invasive respiratory support, the answer is an overwhelming yes, I think, from all of us, because it is something that can help augment the work of breathing.
Yep.
And so it is therefore supporting respiration or respiratory.
I think my general comment is, I think it, clearly it has its niche in home care, if anything, right? And then if you're going to bring it into the acute care environment, my experience with it is that I would have a difficult time seeing it implemented in an emergent environment. Put it that way.
Right.
Right.
It is not kind of an easy to apply. I mean, it's not hard. It's not hard, but it is not. It is not a mask or a prong or whatever have you, right? That's there. There's a fitting that's involved with it, and getting the cuirass, properly applied so that the negative pressure is functional, essentially.
Yeah.
And so it was a little delicate, and even during its application when we were using it, because we were using it in prolonging, in long runs, 12 to 14 to 16-hour runs, on patients that were on VV ECMO, just to kind of set that up, I guess, a little bit without going too far into it, it was patients that were, so, their run was 40, 50, 60 days long, and positive pressure was not opening their lung. It was, in fact, only just creating so much more harm. And, it was, what else do you got? And that's all I had. I was like, well, let's try this, And so, we started off with, just because I was hesitant about its duality in putting positive pressure with a negative pressure and creating a larger transpulmonary pressure and harm. I started off with patients that were just taken off of the ventilator. I just put them on trach mask, and then did for like really long, continuous negative pressure runs, not inspiratory and expiratory runs. As I gained more confidence, I started dropping balloons in them and really understood the transpulmonary pressure and the mechanics, and then started to mix the two of them. These were small little case things. I have yet to write it up, but it certainly wasn't applied early. It was salvage. What else can we do type of thing, but it would not be something that you would wheel into the ED and say this is going to be great. That is not going to be your experience with it.
What little bit I do understand about the nuances are that exactly what you just said, that the little nuances of this support modality aren't really conducive to urgent or emergent sort of applications. We're running really short in time here. I wanted John and Joe to just, if you don't mind, 30 seconds or so on the issues with transporting on non-invasive ventilation.
All right, real quick, and we'll discuss high flow next month. But when it comes to non-invasive in transport, my biggest thing is having oxygen supply. So you have a supply and demand with your patients. So that would be a huge concern of mine. So, Joe.
I agree. On the CPAP, BiPAP side, you are doing a lot more work on portable oxygen. So your mask leak, controlling that is going to be a big issue, because I'm sure John and probably a lot of other people can echo. We've seen mask leaks drain an E-cylinder in 5 minutes for the patients on a high O2 demand. And when that's all you've got, that's not a good place to be in. High flow has really magnified that, like to the point that some places aren't able to do transports because they don't have the O2 demand on their vehicles to do it. And they're having their
we
they're
published
faced
that
with
paper
large.
in Air Medical Journal for that. Yep.
Yeah, we'll talk about that more next time. But there's a huge financial cost. It's a big magnitude to upgrade an ambulance to have O2 supply. It is a huge cost to upgrade an aircraft to be able to maintain O2 supply.
All right. Well, thank you. Tom, you want to start going over these?
Yeah, I'm just going to take 10 seconds to answer this one because this one's been sitting in the comment. So this is someone who's applied BiPAP on themselves the other day and was surprised. I'm assuming they mean the exhaled tidal volume rather than expiratory. I'm assuming they mean exhaled tidal volume of 800 to 1100. And I'm just going to simply say, I'm assuming you have normal lung compliance. So let's say you're on the low end of normal compliance for someone who's just spontaneously breathing naturally. Your compliance is probably at least 100 mils per centimeter of water. So if you think about it, in this scenario, 10 on 5, you're applying, assuming 10 is your inspiratory maximum pressure. If it isn't, then it's different. But if you're applying 5 centimeters of water to your lungs, that's 5 times 100 with 100 mils per centimeter of water. So you're adding 500 mils to your inspiratory tidal volume by applying BiPAP to your face if you have normal compliance. So this is why your tidal volumes would be 800 to 1100. Chances are your normal tidal volume is around 450 or so, and you're adding 500 mils just based on your compliance and the positive pressure you're adding. So we'd have to remember that when you don't need BiPAP, you don't need BiPAP. You're going to have really high tidal volumes. When we apply BiPAP on many patients, they're going to have challenging respiratory system mechanics that oftentimes don't allow that much volume to be able to be delivered to the patient, whether it's due to high resistance or high compliance. Anyone else can comment if they disagree, or we can just move on. But I feel like this is very normal to see extremely high tidal volumes. And sometimes if you've never worn BiPAP and you put it on yourself, you're usually surprised how much volume you're getting. But that's why. It's because you have normal compliance.
Agree. And it's important to know your machine too.
Yeah.
Because that particular example would have been 15 over 5, not 10.
Yeah, because if the Hamilton on BiPAP, so this would be 10 centimeters of water. So again, if your compliance is 100, you're adding a liter to your tidal volume. Just by simple math. You're potentially, now of course you're leaking some of that 7% leak is going to minimize some of that volume, but okay, let's get on to what do the guidelines say. I'm not going to use this slide, sorry Keith, because it's almost impossible to read. I do have this summarization. This is from 2017. This is the ERS and ATS guidelines for non-invasive ventilation. And again, this is referring essentially to non-invasive ventilation or non-invasive positive pressure ventilation, as Danielle mentioned in the comments, which traditionally was what NIV was. And these guidelines were published in 2017. There were previous ones in 2011. There's now since been additional ERS guidelines that include high flow nasal cannula, which I have a slide on the next one. But essentially, the strongest recommendation has not changed since 2011, and that's hypercapnia with COPD exacerbation and patients with cardiogenic pulmonary edema. And for that example, for cardiogenic pulmonary edema, there's not a huge distinction between CPAP and bilevel positive pressure. So essentially, you could use either or. But strong recommendations. So these are the classic patients. Conditional recommendation for immunocompromised patients, postoperative patients, palliative care patients, trauma patients. And then this one is one that I like to highlight sometimes. It's the immediately after extubation in high-risk patients. So this is you pull the tube out and you put BiPAP on immediately, because this is very different than the conditional recommendation against, which is the next one down. And one of the options is post-extubation respiratory failure. So I think many times we confuse these two things as clinicians. We might get told 6 hours after someone gets extubated that, you know what, they don't look good, let's try BiPAP. There's actually a conditional recommendation against doing that, simply because patients that were applied NIV after hours of failing NIV had worse outcomes. So it's not something that is mean. So essentially what they're saying is you should probably reintubate that patient. This is not the prophylactic use. And then where they have, so the conditional recommendation against, which means based on the data we have, which isn't a lot if they don't have a strong recommendation, preventing hypercapnia, there's no reason they have no evidence to suggest that we should use it to prevent hypercapnia in someone who has COPD but is not hypercapnic. And of course, that post-extubation respiratory failure, there's a recommendation against it, that conditional. And then where they have no recommendation for or against, just simply on lack of a lot of data, or data that is confusing, meaning some are beneficial, some studies are beneficial, some are not. That's acute asthma exacerbation, de novo respiratory failure, which is essentially respiratory failure not related to chronic conditions, cardiac or respiratory conditions. So this, something like pneumonia would be classified if the patient didn't have COPD. De novo respiratory failure, something like community-acquired pneumonia would be that. And then pandemic viral illness. And this is simply because at the time of these guidelines, we didn't have a whole lot of evidence about, we had SARS from 2003, where one study said we shouldn't do it. And some guidelines said they shouldn't do it simply because there was a spread of SARS for patients that were applied NIV. This actually, I think this stems from a Toronto experience, to be honest, the hospital I used to work at when SARS was around. But since then, we haven't had good evidence to suggest we shouldn't provide NIV on patients with viral illness due to a pandemic if we're using proper PPE, because the Toronto scenario was we weren't prepared. We weren't using proper PPE at the time, and this was for SARS-1 in 2003. In terms of the ERS guidelines, they do include high-flow nasal cannulas. So this is just a summary, and all of these recommendations were conditional. I just have some of them here on this slide, where over conventional oxygen therapy, they're suggesting high flow, but I'm just going to skip that, and we'll talk about that on the next session where we're actually discussing high-flow nasal cannula. But if you look further, just below that, high-flow nasal cannula over NIV for hypoxemic respiratory failure. So this would also classify those de novo respiratory failure patients likely. And then if you look down below that, high flow over conventional in terms of during breaks from NIV. So there's evidence to suggest that when you take breaks off NIV, providing high flow within those breaks actually is beneficial. So there was a study of post-extubation high-risk patients where they extubated them and used NIV or high flow, but the NIV patients, they used high flow during breaks on NIV, and those patients did significantly better, particularly the hypercarbic ones, which actually makes perfect sense. And then as you scroll down, high flow or NIV post-operatively in high-risk patients. So either or is supported by evidence, again, conditional evidence. And then if you look right down at the bottom, to NIV over high flow over conventional oxygen therapy post-extubation, and then NIV over high flow for hypercapnic failure, which I think is, again, it's been very consistent with hypercapnic failure over the years. There's some ARDS guidelines recently that were published. These are new ARDS guidelines, and they actually do address not only NIV, but they also have sub-recommendations related to COVID-19 because it was so prevalent in the last 3 years, providing non-invasive respiratory support for these patients. So their recommendations for in non-mechanically ventilated patients with acute hypoxic respiratory failure due to cardiogenic pulmonary edema, obesity, hypoventilation, or acute exacerbation of COPD, does CPAP or NIV as compared to conventional oxygen therapy reduce mortality? They're unable to make a recommendation for or against for the treatment of acute hypoxic respiratory failure in terms of over conventional oxygen therapy to reduce mortality. So there's no evidence to suggest that you're going to save a life doing that, but they do suggest the use of CPAP over conventional therapy to reduce risk of intubation in patients with acute respiratory failure due to COVID-19, and they were unable to make a recommendation for or against the use of CPAP over conventional therapy to reduce mortality. So the evidence suggests that CPAP is better than conventional oxygen therapy for reducing intubation, but there's no difference in mortality outcome. And then in patients treated with CPAP or NIV for acute hypoxemic respiratory failure, does the helmet interface reduce intubation or mortality? They're unable to make a recommendation for or against using the helmet interface to reduce intubation or mortality. And then in patients with acute hypoxemic respiratory failure, does NIV compared to CPAP reduce mortality or intubation? Again, unable to make recommendations. So they just acknowledge that although we've used it a whole lot in the last few years, we still have insufficient evidence to suggest one is like overwhelmingly better in terms of mortality outcomes, but certainly there are outcomes associated with reducing intubation. I'll stop talking now because it's 2:00 and anybody else can add some comments. I just thought I'd hammer through those recommendations there, or those guidelines, because that's what they say.
Keith, before we go, can I add one more piece?
Yes, sir.
I just want to direct anybody who is more interested in the finer details of non-invasive ventilation and non-invasive respiratory support. In 2019, a series of papers were published. Actually, Tom chaired that group of us that participated in a journal conference where we actually addressed various issues associated with non-invasive respiratory support. And so that's in Respiratory Care Journal. That's in June of 2019. Papers that range from the physiologic effects of non-invasive ventilation, ventilator-induced lung injury, hypoxemic respiratory failure, hypercapnic, all the way through these concepts that we're still debate about non-invasive respiratory support at the end of life, and so on and so forth. So for those of you that are looking to increase your knowledge and you really want to go into some of the topics that we discussed today, but much deeper, there's a paper that addresses most of these topics with quite a bit of detail. So Tom just put the URL there for you. And again, it's you can find it under the archives, under the content tab of Respiratory Care Journal. Again, it's the June issue of 2019. Yep, right there. So lots of different papers. I can bore you with mine on ventilators for NIV or acute for adults, but a lot of these are really good papers that go into quite a bit of depth into these topics that we talked about today.
I
Excellent.
think I would end with this too. Just my, we didn't kind of get to a lot of this. I have a really kind of strong feeling, and I kind of make it known to everybody that the use of NIV, especially in patients that have a ton of work, we've touched on a little bit, but it isn't something that is of the ilk, well, it can't hurt. Right? Like it can't hurt. We should do this. And we tend not to maybe necessarily monitor it in the same way that we would do something else, right? Especially invasively. And so we talked about patient self-inflicted lung injury and that sort of thing. And I think we just have this general idea, well, we didn't intubate them. We've put them on a mask or we've put them on this and we don't, and it can't hurt, right? Let's try it. It can't hurt. But I think we know so much better now that if you don't understand transpulmonary pressure and the issues that are going on with lung mechanics during high work, you should really, really look into it. And we need to be better at figuring out ways to monitor these patients for those issues, right? We have yet to kind of get there, in some way that is not super invasive, but we do understand that it is something that can hurt, and so it isn't benign. Try it and see type of thing. And I think it's important to kind of leave with that. We talked about all the good that can come of it, but not necessarily the bad if we aren't paying attention to it.
Well said.
Yep.
Yeah, I couldn't agree more, Eric. Couldn't agree more. I wish we had more time. Obviously, we could all talk about this for a lot longer. I will, once Tom gets it to me, I will get the video of this out so that you can share it with people. I'll put it on LinkedIn. And I'll also put the link to the journal conference that Brady was describing. I'll also share that link as well. So I want to thank you guys all again. Were there any other questions, Tom? Anybody had
Just a few that I didn't focus on. There was one, do we consider AVAPs to be set up for BiPAP? I don't think routinely and in critical care, it's just not something we use. This is more used in the home care setting, I believe. There's some potential risks using it in acute care, particularly when patients have high work of breathing and are demanding significant tidal volume or with complicated respiratory mechanics. So this is not something typically used in acute care, and we are focusing these talks on critical acute care. So not for the purpose of what we've been discussing. And then just some more comments about the ventilator and flow. Like Mark was just adding some additional comments about the flow like the vent targeting control systems, et cetera. So I didn't continue dwelling on those questions as well. Sorry, Mark.
Good deal. If anyone that's on has follow-up questions, then reach out to me and I can get them to the panel. Also, stay tuned for times and dates for April's panel discussion, which will be on high flow support. And gosh, I can't remember. Am I supposed to say anything else? Don't forget to reach out to me if you have suggestions for future topics. And I guess that's it. Anybody have any closing discussion? I think that we did a pretty good job of covering most aspects of non-invasive. All right, gentlemen. Thank you so much.
All right.
Let's have a good
Take
day.
care.
Take care, everybody. Bye.
Bye.